Hey, everybody. This is Sarah Esman. This is my first Un-meeting. Are we going to self-create, or is there a moderator that's going to message?
Well, I'm supposed to be the moderator. Hi, I'm Jessica Cooke Bailey. I'm an assistant professor in population and quantitative health sciences here at Case Western. This is my first Un-meeting as well. And so I think I'm just here to, kind of help facilitate, like, what questions do we have? What do y'all want to know? What do you want to ask? Dominic, great presentation.
I would agree. I'm going to try to fix my camera, but I'm going to pose a two-parter question to Dominic. Thank you so much for your presentation. I was curious, I caught your careful delivery with regards to not wanting to diss any hospital provider system. That's always an important relationship to any clinic like you're running. And I just was curious, what's been most helpful from those partners with regards to some of the things you're lifting up as high priority? And I don't think I heard you mention research anywhere. So I'm just curious to know what you make of research interests and prioritization. And thank you.
Yeah, great question. Thank you. I'll speak to some time in Cincinnati. I've been in Cleveland for 10 months now, so still building those relationships. But I would say the organization does have some strong partnerships with our local hospital systems. But in Cincinnati, I think that collaboration formed in many different ways. With Cincinnati Children's, they have a large, wing of their organization that's focused on community health and public health and population health. And they share those resources by training and educating organizations around quality improvement, but also sharing their data expertise when it comes along with analytics or, navigating or intersecting our healthcare data versus what we're getting from a community health data perspective. We also had a strong partnership with University of Cincinnati and UC Health. So in that formed in both from a capital dollars being provided to opening a new health center in one of our the neighborhoods in the city that had the worst outcome, the worst life expectancy across the city. So in that sense, expanding access to care. Here in Cleveland, we do have some strong partnerships. I think they can grow further. But one of the key things is just sharing the resources, right? There's expertise here on this call, and I'm sure at all of our hospital systems that we can't afford to purchase on our own. And part of that is research. Part of that is the analytics around what is going on around the community. Many times, we're using data that is, years, sometimes decades old around what we need to provide to our community, especially with the research data, where our partners, our research institutions probably have more recent and more accurate and timely information that we can use to be responsive to what's going on across our neighborhoods. So I think that is the approach I would take, but more than anything, there needs to be stronger partnerships and collaboration, sharing of resources, and making sure that there's value add on both sides. To your point, there is a key tenet there around trust, and I'm acutely aware that when we talk about health disparities, the patients that we serve, 80% of our patients are below the 200% of the poverty level. So when you talk about underserved populations, I understand and appreciate that that's a group that doesn't always interact or participate in research as much as we would like. And our institutions like Neighborhood Family Practice have the trust of our patients that is more likely to convince them to participate whenever we're working with a partner that is doing research. So how do we manage that in a way that it doesn't create organization fatigue, both from the organization, but also from our patients? And then also make sure that the information that we learned from the research and solutions that are developed, especially in our larger hospital systems and our academic institutions, are pushed and put back into those community health centers. So if we're a part of the research, but we can't implement the solutions, or we're not at the table to talk about what those look like, then we're sitting here saying, where does the value of us participating other than our patients and that information being shared and used in the right way, but also not in a way that it improves the health of those individuals that are participating. I hope that answers your question, Sarah. Yeah.
Awesome. Love that. Okay. I'm gonna say, let's go with Amy Sheehan. I see your hand raised. I can only see a couple of people at a time, so sorry. I'm going in the wrong order.
Sure, thank you. And I guess I'll kind of pick, first of all, welcome. I'm so glad to meet you. You had very big shoes to step into, and you've obviously done so with aplomb. I guess I'll kind of riff on the research question and discussion, and that is the electronic health record transformation has obviously changed everything, especially with research, and with the pandemic causing the immediate transition to digital communications and interactions with patients. I know NFP got one of the first FCC grants to help with that process. I just wondered what you can say about the extent to which your patients are able to connect electronically with healthcare, and whether you all have built relationships with the local digital inclusion ecosystem in Cleveland, which is really among the very strongest in the country.
Very important question. I don't have a great answer on our patients and their ability to connect and use leverage the technology that comes with our electronic health record. I do know that our patients' participation and use of MyChart. So we're one of few, for those who don't know, health centers that have access to Epic as our health record, right? So you think that's one of the best electronic health records out there. But what I always say is that we don't maximize the use of it. And you're paying a lot for a tool that we don't always get the best out of, both us or our patients. But when it comes to our MyChart adoption, it's very high, especially when we look at our peers across other like institutions. The key thing, I know that was a fear of mine as organizations across the country moved further to telehealth and providing services electronically, is that divide or that would contribute to those health disparities that are already prevalent. I think it's too early to say, how that is playing out. I'm happy with our participation. The challenge, though, is that we have to pay for those patients that are on MyChart. So there's a cost, right? There's value to it, but also our Epic provider charges us for every patient that participates on MyChart and that uses those systems. We just got an increase here recently on the rate of that. And, we're going to continue to push forward because we think there's value, not even just from the telehealth perspective, but having, and allowing our patients to interact with our providers in a way that they trying to prevent them from going to the hospitals and ERs for things that are not appropriate. So there's a lot of value from a value-based care and a high value care perspective. But there are some challenges that comes along with that. But I don't think we're leveraging our health record enough, both from a healthcare perspective or from a research perspective. And I know that one thing that I really want to push for my organization to do a better job of is connecting our patients to resources and really speaking more about social determinants of health. I know that our partners like UH and Metro, I think, have systems to where when they screen the patient, they can connect them directly to social resources through Epic. The challenge is, there's different organizations out there. We don't have them currently have those systems, so we're working outside of that, and that's a key tenet for us. To connect our patients to services, but it's very manual and time intensive. So there's some work to be done in that space.
Just as a comment, the big three health systems are all using Unite Us as a same platform, and we've worked with them to include the organizations that help people get connected and get the free internet and the like. And so, I hope you all will consider that, because it's just a great opportunity for our community to have everyone using the same platform.
Yeah, thank you for that. And I've done some research and we're aware of it. and interested in implementing it. I think, and glad to see that it is integrated with Epic for our hospital systems. Our Epic provider is an organization called Ocean, is based out in Oregon. So there is a cost for us for that integration. And when the time comes, if we're able to leverage that, we're hoping that we can find some partners that will help pay the cost of that integration or that bringing that system into our Epic platform. But we know that's already been done. So hopefully that's not a substantial out-of-pocket cost. Thanks, Amy.
I'll stick some ideas in the chat. Thank you.
Sure. Please reach out via email, and also love to keep that conversation going.
I'm just listening.
This is great. Can we go to Jeff Dusek and so he can ask his question?
Sure. This also fits in the research realm. So I'm at Connor Whole Health, part of UH. This is a group that does integrative health research in delivery. So acupuncture, mind-body therapies, yoga, etc., which have not generally been, as we've not done a good job of integrating in a lot of different environments. So I'd love to figure out, I love the kind of co-creation of working with communities. So I've done some research when I was in Minneapolis, working with one of the community centers on a high blood pressure study. And we kind of co-created this with Mass General. So just trying to put some ideas out there, how one could put out ideas, co-create with participants. Again, as Sal mentioned, research has to include everyone's perspective. So just want to put out there that we'd be very interested in trying to find ways to partner in ways with you all, just to make sure that we're making sure that we can find creative ways to work together. Ideally, put in some grant proposals that would offer support to both sides. So we actually want to make sure this would be a win-win for everybody, but just put out there how best to do that and work with you all.
Yeah, I would say reach out. You know, we're an organization. Okay. We believe in being a learning organization. We believe in being a teaching organization, and participating. We have a strong relationship with CASE and other institutions across the region around research and partnering in that aspect. So if you reach out to me, I can connect you with our team that leads and reviews those and participates in that process. But would love to discuss that. We're talking internally about how we can offer some of those key modalities that are not, prescription medications, right? When you talk about meditation and acupuncture and even chiropractor services, and the thing that we struggle with is, in many of the communities that we serve, our Hispanic community, our African American community, those are not modalities that are known or trusted. So I would love to hear about other organizations that serve a similar population that are using them and what that uptake was like, but also what the outcomes have been. But I know it's something that we've discussed, and I think interested in either adding into our practice or working with a partner to make those services available, because we know that we can't depend completely on medications and prescriptions to manage some of these things that our patients are dealing with.
Exactly.
So we'd love to chat more about that.
Just a quick follow-up. I currently have a NIH R01, and it's a multi-site feasibility study. We've got Vanderbilt, UCSD, Cleveland Medical Center, and it's acupuncture in the ED to reduce acute pain and look to see what kind of medications are used. So we're all about non-pharmacologic, how we coexist with pharmacology. At Cleveland Medical Center, uniquely, we'd recruited 80% of our participants are African-American. So again, we're really understanding that if we bring the therapies to where people are getting care, not necessarily for that purpose, but it can augment with the clinical care they're receiving, that brings a lot more inclusiveness than we can see if it's a very complex, have to go to some clinic that's, a bus ride away or whatever. It becomes very complicated. So I feel like we can partner. And again, I think there's a lot of openness to do so. So just one example of where we were able to do that successfully. So I feel like future collaborations can certainly be positive.
Yes, for sure. We'd love to hear more. I put my email into the chat for anybody.
Thank you. That was perfect. That's great. Thank you. And I appreciate your 4x4. It was really quite good.
Thank you.
Dr. Xian, do you have another question or input? Your hand is up. Okay. I don't know how to remove that. This is really awesome. Any other, what do we want to keep talking about? I'm really impressed that you've only been here for 10 months. I didn't know that. Wow. Seems like you're doing great. Already integrated and having so many ideas. This is really, really cool. So,
We have a hand up from PJ.
Yeah,
Come on.
oh, great. Okay. Hi.
thank you. I have a couple reflections that I'll share. Jeff, my partner, he works at Cleveland Clinic as a yoga instructor, and they are working on something similar, rolling out at different sites. And he's actually co-facilitating one of these sessions, which is why I got invited to this today. But I'll encourage him to reach out to you and kind of knowledge share on that. It sounds like some tangential learnings could be had there between the clinic and UH. I'll also share, I am joining Better Health Partnership. This is my second week after working at Unite Us for about a year and a half. And I did hear in the front, not to talk up your organization, but I would highly recommend everyone, if you're not using that, to check out the website. I think it's a phenomenal tool that can connect organizations systematically. And to that point, that brings me to my question. I'll direct it at Domonic, but I would love to hear from others as well. I'm very new to the cross-organization collaboration space here in Cleveland, and I think I'm already, you've sparked ideas in me to think broader. When I hear health system, what does that really mean? Who should be at the table? Who should I be encouraging we collaborate with? For someone that's kind of newer to that, and especially just getting a better understanding of community health centers, what kind of should be a trigger for, we should talk with community health centers, we should bring them to the table? I know that might be a bit of a broad question. I'm kind of asking that as someone new to this kind of space. So, any insights on that?
No, it's a great question. One thing I always say, and again, it's nothing. It's not the fault of our health systems, but whenever we talk about community health or healthcare, whether it be legislators, cities, counties, state, they go straight to those hospital systems, and then things are decided, and then community health centers end up implementing, because we're seeing the patients that are really struggling the most when it comes to poverty or social determinants of all these other factors. So anytime that we can be at the table early, be a part of those discussions, and be a real partner when we talk about equitable partnership, equitable research and all those kind of things, I think we have to be at the table early on. And so many times we're brought on last or at the end, and they say, hey, can you go do this? We've been meeting for a year or 2 years or 6 months, and this is what we would like to do. And they hand the baton off from us. And we like, well, our patients, our community, our neighborhoods, they won't receive that in the way that you want, or that won't have the desired outcome. So I think anytime you have anything that's public health, population health, community health, or healthcare in general focus, reach out and ask the question, say, hey, would there be value add for you to attend, or anybody in your organization that would be interested in joining? And we would appreciate that, because again, far too often we're forgotten about, but we are a key part of the implementation, especially when we talk about if we're addressing things from our underserved communities. And I do want to touch on, I think, a question for Jeff or for others. We've talked about yoga, and then PJ, you just touched on this also, and meditation and some of those other things for our patients. Is there research going on the impact for our staff? We talk in healthcare about burnout, especially from our clinicians, a lot about it in our clinicians, but even our frontline, our MAs, our front desk employees. Is there any research going on around how we can leverage and use those practices, those tools to support our workforce and really build that resilience that's so important for sustainability in the work that we're doing?
I'll jump in. Thanks, Dominic. Yes, there is. I was part of actually before I came to UH, I was a chief research officer at a yoga retreat center up in Massachusetts. And we had a program that was for frontline providers. These are police, teachers, firefighters, folks who worked at nonprofits. So there is good evidence. So I can share some of that. And it's a pretty straightforward program. I mean, it's nothing that's, it's very comprehensive, but also very doable for people to bring into their lives. So I can share some resources about that. So yes, there is evidence to support bringing some practices into the workers who have stressful jobs. There's some good evidence.
Thank you.
Mm-hmm. It's a really good point too, because burnout is everywhere.
Clifford, I see you have your hand up.
Yes, thank you. Just a quick question. I work here at UAB in Birmingham, and I work in our CCTS here in the School of Medicine. And so we've been really good about using on the front end community action boards to get sort of early information when researchers want to go in the community and do community engaged research, or physicians need ideas and help of how to connect with people in the community. So I'm just wondering, from your experiences in Cleveland, have you been able to plug in or have any connections with any community action boards that may give you feedback as you navigate the system and reach out to patients?
I would say I haven't had that experience. We have a great relationship, and we're very intentional about our community engagement work, and really reaching out and pulling our community in and leveraging that feedback that we get in that way to drive our partnerships and our collaboration. But I would love to hear from some of the other researchers that are local, here in Cleveland, but across, if you're representing other neighborhoods, are you doing similar things to what Cliff and his team are doing at UAB when it comes to reaching out to community boards and finding and leveraging their input to drive your research and feedback?
I'll speak for Connor at UH. We have not, but we'd love to. I think that's part of the conversation. That's what I was trying to ask earlier. How do we co-create? How do we bring a kernel of an idea to a community and say, what is important to you, and how do we work together? So I would love to facilitate that kind of work, because that's the part that really makes a difference. I mean, I'm tired of researchers coming with really great ideas that don't translate to the community, and it's just not. I'm not interested anymore. So I would love to help. I'd love to partner in that kind of conversation. It's critically important.
Yeah, and then for others across Cleveland, PJ, I know that you're new to Better Health Partnership, but we do have a strong relationship with Better Health, to where we pay an annual due for them to convene our FQHCs. So if you want an audience with all of us, I would say reach out to Better Health, and they can probably get you to the table where you meet with all of us and you're not having to pitch something 5 different times, or you can likely do something that is going across all of our organizations, because we're very unique, both geographically, but also the patients that we're serving. So Rita Horschwitz and her team at Better Health Partnership is a great convener of us, and probably a good outreach when you want to bring us together and really engage with the community health centers. But again, you can always reach out directly to.
Dominic, I have a question for you. I'm Nora Singer. I'm at Metro Health, and I'm one of the Recover multiple principal investigators. Grace McCumsey is at UH. We've used our Institute of Hope to put the word out in terms of religious ambassadors, or who are trusted members of the community. But we're almost done with the enrolling of the observational study, but there will be clinical trials coming along that get offered both at Metro and UH. Would this be an appropriate group to engage once those are available, so the word can go out to the community?
I think so. Again, I know that from a research and from a clinical trial perspective, having diverse individuals participate is a key barrier and struggle that has been around for many years. So again, to your point, I do think that's a great place to go. And our providers, our organizations are interested in helping to solve that. and support that work. So please reach out to us.
Okay, thanks.
I see a question from Meredith.
Yes, good morning, everyone. I am Meredith Southwick, and I am one of the people not based in Ohio. Though I did live in Cincinnati for 5 years. My alma mater is Northern Kentucky University for my bachelor's. So, but I am out here at Oregon Health and Science University in Portland, Oregon. So very far away from you all and very early in the morning. Everyone on this call from Portland got on at 7 a.m. So. But my question is actually to not just Dominic, but the group as a whole too, is, we talk a lot about community engagement. And I think that point about the value added and getting people involved so early is so important. And I was wondering, just from the group as a whole, I guess, two things, two different questions. One, what have people found the best way to approach organizations you've never worked with before? Maybe you're just starting to build a relationship. And then the second thing is when we talk about value added, a lot of times on our campus, we try to think about things like, is childcare needed? Is transportation needed? Is, how are we actually paying them? Not just compensating them, but what method is best? And so I was just curious, other parts of the country that are on this call and your experiences, what are those main things you found that really mattered for the populations you were working with?
So a great question, Meredith. I'll wait to see if others want to take that one first. Again, I'm sure it's a challenge that you all face, or that individuals doing research. Anybody found a way to do that well, especially the part where your initial outreach to an organization and you're trying to communicate, but also how you're providing value to the participants in those research studies?
I'm happy to take a stab at the question. Good morning, everybody. My name is Renee Kennedy. I'm at the University of Pittsburgh Clinical and Translational Science Institute. I'm the Senior Community Engagement Coordinator here. So a lot of work that I do and my team does is help bridge the gap between community and researchers. And so one way, we have multiple ways because there's no one size fit all. So I will say that that depending on the community, we really try to meet the community where they're at, and depending on the folks, again, it looks a little bit differently for each community. But a couple different ways that we engage with the community is, again, like you talked about, that value exchange. We really talk to our researchers about vulnerability, right? Because our job here is really important in regards to making sure underrepresented populations are included in research. So that's sexual and gender minority, persons with disabilities, African American, non-English speaking, folks who live in rural areas, pregnant women, NICU babies, older adults. These are the folks who have been historically underrepresented in the research. And so we are actually intentional about our programming and ensuring that those voices are uplifted and centered in these research spaces. And so we always talk to our researchers about sharing that, what is your why? Because for most of our community members, this is their everyday life. The thing that you're trying to research is what they may be experiencing every single day. And how do we humanize the research process? Because there's all these different processes and IRBs and all these different research terms that can be extremely scary for community members. And so we always ensure to give the power back to the community in the way of providing lots of education, providing lots of definitions whenever we're giving presentations, providing photographs and pictures to ensure that, if you're not a reader, then there's an image to go with it. If you're not a reader or an imager, maybe a video that, really goes over well. There's ways of doing video consent. I'm not sure if you all are sure that everyone should be aware of, like, All of Us, the All of Us research study. When here at Pitt, we actually have a video consent for folks to go through, because, again, giving someone a consent that's 20 pages long, size, font 8, and all these huge words and, different terminologies that just doesn't translate well. And it is our duty for, being a part of a university and having lots of different resources, also understanding that, hey, you may be working on a diabetes research study. However, yes, the community could be affected by diabetes, but they may be more focused on dental. Like, hey, we don't have dental. You don't have dental. And you're like, well, I'm not a dental researcher. However, I'm part of the University of Pittsburgh. I know that there's a school of dental. So there's nothing for me to add a dental hygienist to whatever I'm doing. So again, not going in with your own agenda is really important. And I hate to be on a soapbox. I'm not looking to see if anyone else's hand is up. But just those are just some of the really key things that I would just like to put out there is, you know, what else could you bring? Ensuring that you're not doing work on the community or research on the community, but with the community. And I heard a lot of folks say, you know, making sure community is involved at every step. So that's whenever we say every step, not once you already developed a proposal, you already submitted it, but prior to that, prior to like the elementary, the preschool part of it. Because I like to look at research as you know, as you continue to do community engagement, it gets better and better as you continue to build trust in the community. And here at Pitt, we call it research reciprocity. And so again, really honing in on that value exchange and building trust in the community. Thank you.
Yeah, thank you for that. A lot of good information there. Amanda, I see that your hand was up. Did you have a question or were you going to tag on to?
I was going to add on if that's okay.
Please go.
Yes. So I'm Amanda. I am a clinical project manager at the Cleveland Clinic in the Center for Clinical Research, Research Unit. So that's one of our primary goals in our group is, of course, to diversify research studies. And so we've been doing things like community health fairs, of course, and some community service events like lot cleanup and Toys for Tots, things of that nature out in Cuyahoga County. And recently we are trying to build a network throughout Cuyahoga County, but also I'm from Lorain County and I have a lot of contacts out there. So it's been great trying to build those relationships out there and with other healthcare systems. Actually, Mercy Health puts on a lot of health fairs. So we've been invited to those and people are very excited. They know about research and they want to know more. So it's been great just being candid and open with people and honest and just the ask. One of my colleagues keeps saying, you know, don't focus so much on the past of, oh, we have to build so much trust or people, you know, have misgivings about research. That does exist, but you'll never know unless you ask. And you have to, in order to include people, you need to ask. So that's been our approach, is having to ask, as Ms. Kennedy said, you know, having your why, doing the work ahead of time. And we've been fortunate